Welcome, everyone. Thank you for attending our first Ask the Experts series event, Prostate Cancer Genetics Experts Discuss Risk, Screening, and Treatment. I'm Juanita Rogers, Vice President of Health Education and Communication at Force, and I will be your host for this event. FORCE stands for Facing Our Risk of Cancer Empowered. We are a national nonprofit organization devoted to improving lives of individuals and families facing hereditary breast, ovarian, pancreatic, prostate, colorectal, and endometrial cancers. Our community includes people with a BRCA, ATM, PALB2, CHEK2, PTEN, and other inherited gene mutations, and those diagnosed with Lynch syndrome. We accomplish our mission not just through our 4 pillars of support, advocacy and public policy, education, and research, but also with strong partnerships with other organizations. You can find out more about our programs by visiting our website at facingourrisk.org. I would like to take a brief moment to thank our program sponsors for their support. Our presenting sponsor is AstraZeneca. Our empowerment sponsors are Lilly and Merck. Our affinity sponsors are ASI and GSK. And our community sponsors, Foundation Medicine and Pfizer. So just a few details about today's webinar that's going to be in 2 portions. The first portion will be an interview with our experts, and I will introduce our experts in just a moment. We will record this portion of the webinar. Also, during this portion, you will see some slides that will just help to reinforce certain points and provide additional information or links that will be helpful for you. We will make the slides available after the presentation, but for your awareness, we will be covering the topics of risk, screening, early stage treatment, late stage treatment, and clinical trials. The interview will then be followed by a smaller breakout rooms, and you will have the opportunity to ask questions of our panelists during the breakout room portion. We will not record the breakout groups. And here are our speakers for today. Dr. Raina McKay is a medical oncologist at the University of California, San Diego. Dr. Jason Hafron is a urologist at the Michigan Institute of Urology. And Angela Trepanier is a certified genetic counselor at Wayne State School of Medicine. All 3 panelists are also members of Force's Scientific Advisory Board. Thank you, experts, for being here, and our speakers will make sure to define any terms or acronyms that they may use as we're having the conversation, but just as a reminder, we are not providing medical advice. Please always consult your doctor or medical provider about your medical options. So our first questions are going to start with prostate cancer risk. Angie, we'll start with you. There is a lot of confusion about prostate cancer risk among the hereditary cancer community, and it seems that research has been mixed. In general, which genes are linked to a higher risk for prostate cancer?
Thank you, Anita. Yes, it is confusing. And part of the reason why it's confusing is because there is new information that's developing all the time that tells us which genes are associated with hereditary prostate cancer, so prostate cancer that runs in families, and what risks are associated with those genes, like what the risk of prostate cancer is, and whether there are any other features like aggressive prostate cancer associated with particular genes. And that's just part of the nature of genomic medicine, is that as we test more people and learn more about different genes, we get different information. And so anybody interested in genetic counseling or testing should consult with a genetic counselor or a physician who's knowledgeable about hereditary cancer genetics, and they will give you the most up-to-date background. But the genes that have strong evidence to date are listed here: BRCA1 and 2. They're called the breast cancer 1 and 2 genes, and as the name suggests, they're associated with an increased risk of prostate cancer, but also breast cancer, ovarian cancer, pancreatic cancer, and some other cancers too. HOXB13 is another gene that is a strong evidence gene. And then TP53 is associated with not just prostate cancer, but other cancers like breast, osteosarcomas. There's a whole bunch of different cancers associated with that one. So those are the strong evidence genes, but there are a lot of other genes that are associated with some emerging evidence or moderate evidence. And those include the ones listed here: ATM, CHEK2, PALB2, and then the Lynch syndrome genes, especially MSH2 and MSH6. They're associated with colorectal cancer, endometrial cancer, and prostate cancer, as well as gastric and some other cancers. And the only reason why I tell you about those other cancers is that when you're thinking about your family history, recognizing that these genes are associated with multiple cancers can help you think about what questions to ask your family members and what to look for in your history. And there's a study for men at high genetic risk for prostate cancer that is trying to answer some of these questions. What genes are associated and what are the risks associated with each gene? And it's through research that we start to get answers. And so if you have prostate cancer and you're interested, this might be a good study to participate in.
Thank you so much. And we have heard that some inherited mutations are linked to a higher risk for aggressive prostate cancers and cancers that are more likely to spread beyond the prostate. Do all inherited mutations increase the risk for aggressive prostate cancer, or are some genes more likely than others to cause more aggressive disease?
I think Dr. McKay was going to answer that question.
Yeah, I mean, not all inherited mutations carry the same risk. BRCA2 mutations are the most strongly associated with aggressive, high-grade prostate cancer. We have the most data for patients who have those alterations. BRCA1 and ATM mutations have also been linked to aggressive disease, but to a lesser extent than we see with BRCA2. And now for the Lynch syndrome genes, and just to kind of review these genes, this is MLH1, MSH2, MSH6, PMS2, and EpCAM. These may increase risk, but it's really not clear the association with disease aggressiveness, so like increasing grade or stage of prostate cancer. There's also been increasing data around HOXB13 mutations that are typically associated with earlier onset disease, but not necessarily more aggressive disease. And at the present time, that has not been utilized to adjust treatment decisions. So really the key point is that genetic testing helps identify those who need more intensive screening or earlier interventions. And there are stipulations around who should be tested. I think one of the limitations is that certain populations, such as African Americans and Hispanic patients with prostate cancer, have really been underrepresented in a lot of the inherited, germline studies. And so we, to really get a full picture of how these genes impact cancer risk, it's critical that we provide all patients with an equitable opportunity to participate in genetic studies and make sure that our genetic studies are actually inclusive of the entire population of men that we screen for prostate cancer and we treat for prostate cancer.
Thank you, Dr. McKay. And we also have some QR codes here up for individuals if they wish to go to Force's webpage for more information. Angie, if there is anything else you want to add, but I also want to ask, who should consider testing for an inherited mutation?
Well, there are guidelines for that right now, but as I mentioned, those can change over time. So at this time, some of the guidelines suggest that we should be offering genetic testing for hereditary prostate cancer to anybody who has a personal history of prostate cancer at any age with any of the following. And so that includes having a diagnosis of metastatic prostate cancer. So that's prostate cancer that's spread to other parts of the body, or anybody with prostate cancer who is of Ashkenazi Jewish ancestry, or also called Northern European Jewish ancestry, just because mutations or changes in BRCA1 and 2 are more common in people who are of Ashkenazi Jewish ancestry, and just by virtue of their ethnicity, they have a higher chance of having a change in one of those genes. Having a family history of one or more close relatives, and that's your siblings and your parents and your children, aunts and uncles or grandparents or cousins on the same side of the family with breast cancer before age 50, male breast cancer, ovarian cancer, pancreatic cancer, or metastatic or high risk prostate cancer. And then finally, if there's 3 or more relatives on the same side of the family with prostate cancer, that's another indication for genetic testing. As Dr. McKay said, just recently added to the guideline, you can consider genetic testing if you have prostate cancer and you're 55 or younger, whether or not it's metastatic or high risk. So those are, like I said, some of the current guidelines. Those are likely to change over time. And so if you have any questions, make sure you ask your physician or a genetic counselor or physician who has experience in hereditary cancer genetics, and they can give you the most up-to-date information and take into consideration your personal history and how this information could impact you.
Very helpful. Thank you. So now we'll move on to the next section about screening. Dr. McKay, when we talk about high-risk screening for prostate cancer, what does that actually mean? And is there a preferred order for the screening?
Very good question. So high-risk screening typically starts at an earlier age. So in the guidelines, shared decision-making really starts around age 50. It's a little bit younger for African-American men at around age 45. But for high-risk individuals, it can be even younger than that, 40 to 45. And depending on the age of onset of anybody in the family who may have prostate cancer, that may also guide earlier testing. The testing includes a PSA, which is prostate-specific antigen. It's a blood test that can be checked to assess for risk of prostate cancer with a digital rectal exam. And while a digital rectal exam has traditionally been part of prostate cancer screening protocols, its clinical utility is actually becoming increasingly debated now that we have multi-parametric MRI. Multi-parametric means multiple parameters, MRIs that can look at the prostate and give superior diagnostic information compared to just a traditional rectal exam, potentially making the physical exam less critical for screening. And then the screening frequency, is more frequent for those high-risk individuals, probably on the order of around once a year, as opposed to every couple of years. And the preferred approach is, PSA first, and then rectal exam, with the caveats that I just recently mentioned, really provide kind of complementary information. And then if the results are abnormal, that generally triggers getting an MRI, which can then potentially further trigger a biopsy. And the timeline is really to continue screening until age 70 to 75, or life expectancy less than 10 years. And that's sort of what's embedded into the guidelines.
It's very helpful. And we're touching on some important points with PSA and DRE. So Dr. Heffron, do you have anything else to add to this?
No, I agree with everything that Dr. McKay brought up. I think PSA sometimes gets a bad rap in the press, but PSA is a very sensitive marker. And the higher the PSA, the higher the likelihood the patient has prostate cancer present. Also, what's nice about PSA, we have some additional markers, a free PSA, and the lower the free PSA, the worse or the more likely that patient has prostate cancer. So it's inverse to a standard PSA. And then PSA density is another factor that we look at to assess the risk of a patient having prostate cancer. So PSA is not a perfect test. There's a lot of variability, but it's the only test and the best test we have for screening. And I agree with Dr. McKay as well. We're doing less and less DREs in the practice. Patients don't want it. Most of the data supports that it's not very sensitive and not very specific. And there's newer technologies that have evolved, including adjuvant biomarkers, as well as the multi-parametric MRI that Dr. McKay mentioned.
Very helpful. Thank you. And we have also heard that there, again, with the promising research, using MRI for prostate cancer screening for those that are high-risk individuals. Dr. McKay, could you or one or both of you speak to the role of MRI for high-risk screening? And is there anything else new on the horizon for prostate cancer screening?
Yeah, very good question. You know, I think multiparametric MRI is really revolutionizing prostate cancer detection, and it can identify suspicious lesions, you know, before proceeding to biopsy and help kind of guide the path around biopsy. You know, like I said, multiparametric MRI is multiple parameters. So in addition to looking at just like anatomically what is there, like where is everything at, there's a lot of enhancement features that are added to really try to identify what areas may be abnormal. It's particularly valuable for high-risk individuals where we really want to try to catch things early on. And also, now that we have this tool, if there is a lesion that's identified that looks abnormal, now it's routine practice to actually do MR-guided biopsies that are a little bit more accurate than just traditional random biopsies. You know, a decade ago, we were largely just doing, you know, template biopsies through the prostate, not necessarily directed at a specific lesion that may be identified, but MRI has been able to really revolutionize that. And on the horizon, now with the advent of AI, there's opportunities for AI-enhanced MRI interpretation. So we're not quite there yet, but I think that is things that is to look forward to in the future. There's also blood-based biomarkers that are being developed and other liquid biopsies that are being developed with the goal of more precise detection, less invasive procedures. But I think those tests are still evolving. I know many patients have like, well, can't I just get a blood test to just tell me if I have cancer or not? And we're not quite there yet, though I think the field is evolving.
And Dr. Hafron, anything to add? Yes, please.
Yeah, MRI has been, you know, disrupted our field significantly. Specifically, we find higher grade lesions. So the Gleason 3+4=7s are the ones that typically show up on an MRI. So we're more likely to find clinically significant prostate cancer versus finding low risk or very low risk Gleason grade group 1 or Gleason 6 prostate cancer because the MRI doesn't pick it up. So with targeted fusion-based biopsies, which is becoming the standard of care, but it's really changed how we evaluate and diagnose prostate cancer today.
Really helpful. Thank you. And Dr. McKay, I'm going to go back to you. When the guidelines say consider screening, or they talk about the importance of shared decision making, which we have here on this slide with regards to screening, shouldn't everyone just have screening? And if not, what questions should people be thinking about and how can they decide?
I think this is a very important question, and I think it's a little bit different than I think maybe the strategy or approach that people may be familiar with for other malignancies. And you know, really the why not universal screening is that there can be both benefits and harms related to screening, and it's not just a one-size-fits-all strategy. So I think we really need to think about the patient that's before us and what are their values, what are their you know, comorbidities, other things going on with them before we embark on this path. There can be false positives, there can be need for unnecessary biopsies, over treatment of slow growing tumors. And we as a field have actually moved away from that. We've moved away from, you know, identifying those lower risk tumors that aren't going to do anything. And there's even question in the field about whether those tumors should even be called cancer. And treatment. So I think the key questions to consider are what's my personal risk based on my family history and genetics? What's my, you know, life expectancy? Screening is less beneficial if people have a life expectancy of less than 10 years, if they've got other comorbidities or illnesses that they're dealing with. And, you know, asking the question of like, how would I want to handle an abnormal result? And am I prepared for further testing, further diagnostics and treatment? And, you know, what are sort of the values about the potential side effects and the treatment itself. So there's a lot of things to factor in, which is why there's this catch-all phrase of shared decision making, because it's really important to know sort of where you stand as a patient and also discuss with your physician or care provider what to do. So again, decision factors, age, overall health, family history, preferences about medical interventions. I think for those that are high-risk individuals that are known to carry a hereditary alteration, it is recommended to consider screening, presuming that these other parameters are considered, because in those individuals, there can be a benefit that outweighs the risk. And ensuring that screening aligns with each unique patient's individual values and circumstances is really critical.
And Dr. Hafren, anything additional or any other considerations for patients who may be within an 45 to 75-year age range, or anything additional you'd like to share here?
No, I agree with Reina. Age is critical, family history is critical, and you have to have an honest discussion with the patient about these, sometimes difficult discussions about, age and risk and life expectancy. It's always challenging in the clinic. I think also you have to talk about the risk of the biopsy. Biopsy is an invasive procedure with risk associated. There's a risk of infection, sepsis, things like that. There's a risk of bleeding afterwards, or risk of urinary retention. So that shared decision-making model also have to talk about the actual risk of the biopsy itself, which is an invasive procedure that can have complications.
Important point. Thank you very much. Before we leave the topic of screening, I just want to touch a little bit on the studies, the trials that you see here on the screen. These are just a few of the prostate screening clinical trials that Force presents some free features on its website, and they are enrolling people with inherited mutations. You can utilize the QR code, but again, these slides will be shared after the presentation. So we're going to move on, and we're going to talk a little bit about diagnosis. Dr. McKay, I'm going to start with you. What happens when someone has an abnormal PSA or MRI? How do you determine if they have prostate cancer?
Yeah, very good question. I think the first step oftentimes is repeating it. If the PSA is abnormal, it's getting a confirmatory test. PSA can fluctuate up and down. There's a lot of things that can make the PSA bounce upward or downward that aren't necessarily cancer. So I think first is just repeating the test. I think getting a multiparametric MRI, as we've talked about, to look for any suspicious areas in the prostate that could be concerning. And if the MRI does show concerning lesions, proceeding with an MRI targeted biopsy. I will caveat that in some scenarios, the MRI may not necessarily show any abnormalities, but the PSA is high enough that you'd still want to proceed with a biopsy, even though the MRI is not necessarily showing a distinct focal lesion. So that needs to also be discussed. Then with regards to the biopsy process, usually there's a local anesthetic and there's a small piece of tissue that's taken through the rectum or the perineum to sample the prostate. And the samples are examined underneath a microscope to identify if there's cancer cells present. And if there are cancer cells present, usually a Gleason score is typically assigned. And that Gleason score gives a little bit of insight into how aggressive underneath the microscope does that cancer look. And the Gleason score is something that is determined by a pathologist. And it basically is asking the question, how much does like normal prostate does the specimen look like? And they kind of grade it based off of what they see. And if there is cancer that is found, sometimes there's a need to do additional testing. There may be a need to test with a bone scan or CT scan to make sure that there's no evidence of disease in other parts of the body. Most prostate cancer that's diagnosed is actually diagnosed localized, without any spread to anywhere. But these additional tests may sometimes be warranted.
And Dr. Hafren, what are some of those additional screening tests or additional points that you want to make sure viewers know tonight?
Yeah, I think Raina brought up a great point. A negative MRI, no lesions on the MRI doesn't mean you don't have cancer, and that's about 20% of the time. So if a patient has a negative MRI and worrisome PSA kinetics or trajectory, not quite frequently, we will still do a biopsy of the prostate. I think also what's exciting, in addition to multiparametric MRI, is that we have these adjuvant urine and blood tests. There's currently 6 approved tests in the guidelines today. And these are great tests because they tell us with higher accuracy whether that patient's elevated PSA is associated with significant prostate cancer. So that also helps us guide who should get biopsied and who can avoid a biopsy. And the best thing about these tests is when they're negative, when the test says there's low likelihood, they're very negative. We call something called negative predictive value. Their negative predictive value is over 90%, which means there's over 90% assuredness or comfort that you don't have a clinically significant prostate cancer. So I think the combination of the MRIs with these adjuvant urine and blood testing has made our job as urologists and the patient's experience much better because we are biopsying the people that need to be biopsied, and the patients that are at low risk can avoid unnecessary biopsy.
Very helpful point. And we are going to move on at this point to talk about more treatment aspects. And Dr. McKay, again, I'll start with you because we hear quite a bit about overtreating. And I'm wondering if that's truly a serious concern, and are prostate cancers in people with inherited mutations automatically high risk, or can they have low risk cancers? A couple of questions for you there.
Oh, thank you for that. I mean, overtreatment certainly is a concern. There are some cancers that grow very slowly, may never cause any problems. They're never going to at all impact that person's life expectancy in any way, shape, or form. And so I think it's really important for us as clinicians to help tease out the cats from the tigers, if you will. So there's a lot of testing that can be done to help tease that out. And it's not every cancer is automatically high risk. And even with inherited mutations, not every inherited mutation is associated with a high risk cancer and needs to be treated in an aggressive fashion. Now, the caveat to that is that we have demonstrated time and time again that BRCA2 carriers do have more aggressive disease. That's the most robust of all of the genetic mutations that I mentioned earlier. We have the most robust data for patients who harbor BRCA2 alterations. But again, not guaranteed, and not everything is black and white. So I think it really needs to be individualized against the patient's genetic testing results, what's their Gleason score, what's their PSA, what's their stage. We put that all together. And some of the tools that Jason just spoke about to help us make a risk determination to guide, okay, what bucket are you going to fall into? Are you going to be in the low, intermediate, high, or very high risk bucket?
Dr. Hafron, anything additional to add as far as overtreating and high risk, or whether there can be low risk cancers within those with inherited mutations?
Yeah, I think I agree with Raina's point. I think urologists have made significant strides over the last decade, reducing overtreatment of low-grade prostate cancer. I know here in Michigan, we're part of a statewide collaborative where we developed a roadmap, or essentially a protocol on how to identify low-risk disease. And a lot of it involves, PSA, Gleason score, a whole litany of tests called genomic classifiers. But what we're proud of in Michigan, based on this protocol that we followed, is that over 90% of patients with low-risk prostate cancer, which is grade group 1 or Gleason 6 prostate cancer, aren't getting treated, and they're put on active surveillance. And active surveillance has become a major tool that we use as urologists to monitor patients with low-risk prostate cancer so that they don't have to go to surgery, they don't have to get treated with radiation. and we can follow them so that if something changes in their disease, that we can jump on it and offer them the appropriate therapy when needed. So I think we've turned the corner on this, especially in Michigan and across the United States, in using active surveillance appropriately. But like Raina said, in a BRCA2 mutation or patients with other mutations, we don't have tons of information, but I think what we know based on single center experience is that these patients tend to have more aggressive disease and probably should not be considered, I mean, for active surveillance, and probably should consider for more aggressive interventions up front, because we know that they don't typically do as well as patients without some of these mutations.
And Dr. Haffern, you just brought up a really great point. We've heard these terms, active surveillance and watchful waiting. Patients might hear that after diagnosis. Either one or both of you, what's the difference between these terms, and when are these options for patients?
Yeah, very good question. And I think sometimes these terms get used interchangeably, but they are in fact very distinct things. So active surveillance is in fact that. It is active. It is intensive monitoring to ensure that there isn't higher risk disease that is there that a patient may have. So, it's usually done in patients who have low risk disease or favorable intermediate risk disease, and you're continuing to monitor with PSA and a rectal exam and intermittent MRI and even intermittent biopsy to prove to yourself time and time again that yes, in fact, this patient has low risk disease. Whereas watchful waiting is a little bit different. It's not intensive monitoring. It's mainly focused on symptom management. It doesn't necessarily include the intensive biopsies or even intensive PSAs. And it's basically saying, we're not going to really do much about this prostate cancer unless this prostate cancer starts to cause problems or cause symptoms or cause somebody to feel unwell. And even though the PSA may be going up, we're not necessarily going to do anything about it if the patient is still doing okay and doing well. And that may be an appropriate strategy for somebody who maybe has many comorbidities. They're on a lot of medications. They've got other, health issues that are going on where it doesn't really make sense to actually treat their underlying prostate cancer. So as I've stated, the active surveillance protocols typically include PSA, which is typically done on a 6-month schedule, so that can be flexible. It typically includes an annual MRI, though that is also flexible depending on how many years into their active surveillance course they are. The intensity of monitoring tends to be a little bit more intense initially when people embark on active surveillance, and usually there's periodic biopsies. The first biopsy, the first confirmatory biopsy, I should say, is probably the most critical, getting that done within 6 months to a year of the first biopsy. But then after that, it can really be spaced out. So and then the goal with active surveillance is that if in fact you find higher risk disease or the Gleason score is changing, or even if the PSA is starting to really escalate dramatically, then that would warrant actually moving forward with definitive treatment. And I'll say the watchful waiting, we've chatted about this, is sort of really more for those older, sicker adults. And there's a clear difference between these two strategies.
This is very helpful. Dr. Haffron, given your extensive background, what can you tell us about who may end up needing surgery to remove their prostate?
Well, the surgery we do is called a radical prostatectomy, or prostate removal. Is generally recommended for men with prostate cancer that hasn't spread outside the prostate gland or is at a stage where surgery is deemed the best treatment option. This type of surgery aims to cure the cancer by removing the entire prostate. Prostatectomies are common and safe, but like most surgeries, they do have some risks and some side effects, so we don't recommend them for all patients, especially patients that have significant comorbidities or other diseases. We typically perform prostatectomies on men under 70 years old who have localized cancer, and again, for cancer that hasn't spread. And just about 96% of prostate surgery in the US is done robotically. This has evolved over the last 20 years, where we make these small incisions in a fan-like configuration below the belly button, and then remove the prostate through the belly, essentially just above the belly button. And robotic surgery has literally revolutionized the quality of our surgeries, improved our continence rates, our sexual function rates, and really decreased the morbidity so that patients can be treated, most of them now today as outpatients, or even just a short stay in the hospital.
It's incredible. Thank you so much for sharing. And Dr. McKay, I understand that you have a clinical trial looking at a new and promising approach to early stage prostate cancer. So first, can you tell us a little bit about PARP inhibitors used to treat prostate cancer, and then tell us more about the approach you're taking for your clinical trial?
Absolutely. So PARP inhibitors are typically a type of targeted therapy that's used to treat advanced prostate cancer. The PARP inhibitors actually have approvals in multiple other diseases as well, in ovarian cancer, in breast cancer. And the PARP, what these PARP inhibitors do is they inhibit a protein in the body called PARP, a protein in the cancer cells called PARP. And this PARP enzymes helps the cancer cells repair their DNA. And what the PARP inhibitors do is that they block this repair, causing the cancer cells who already have a problem repairing their DNA to really not be able to repair their DNA, which essentially causes the cells to die. So you basically have a cell that has a problem with its ability to repair its DNA. And if you cause enough DNA damage in a cancer cell, the cancer cell will actually die. And so if somebody has a hereditary mutation, or their tumor has a mutation that causes the cell to not repair its DNA very well, and then you give a PARP inhibitor that really prevents them from being able to repair their DNA at all, that cell can die. So it's this concept called synthetic lethality, where you have a cell that's kind of addicted to something, and then you give it a drug and it kind of can die because you're blocking that one thing that cell needs, okay? And these drugs have really improved outcomes for patients who have advanced disease, that have genomic alterations. They are life-prolonging drugs in the metastatic setting. But the trial, which we'll talk about, is going to be testing these drugs earlier on. So the whole concept of the Neptune study is basically saying, we know these drugs work, the PARP inhibitors. They're FDA approved for people who have metastatic disease. They're particularly effective in people who have tumors that have genomic alterations in their ability to repair DNA, particularly BRCA1 and BRCA2. And like I said, they're life-prolonging agents. And this trial is actually looking at moving these drugs earlier on. It's basically asking the question of, we know that individuals who have genomic alterations in BRCA1 and BRCA2, we know that they can have more aggressive disease. We know that there are high-risk features, and there are some people that are, despite having surgery, their cancer has a high risk of coming back. And so the way that the Neptune study is designed is that we give 6 months of the PARP inhibitor, which we know works in late-stage disease, before somebody undergoes surgery with hormone therapy, with the hope of decreasing the likelihood that that cancer may come back. And so this study is currently open and accruing patients, and it's open at multiple sites across the US. We can sort of share those sites. It's open at UCSD here, where I'm at. It's open at MSKCC in New York. It's open at Penn in Philadelphia, at Hopkins, MSKCC, Columbia, and Cincinnati. So we've got sites across the US where this study is open and actively enrolling patients. It's enrolling patients who've never had prior treatment for prostate cancer, and largely enrolling patients who have localized disease that are candidates to undergo surgery, okay? And so I think this is going to be an exciting study where super pumped about doing a trial like this, because I think something that's very near and dear to my heart is, it's great to have drugs that work in late stage disease and help patients who have metastatic disease, which is critically important. But how can we cure more patients? How can we actually identify those individuals who are high risk, who are destined to relapse, and give them a therapy that is highly effective and personalized for them to increase their likelihood of cure?
And we want to make sure that information gets to our viewers. So we do have the QR code up, but is there anything else you want to add regarding eligibility before we move on to our next question?
Sure, certainly happy to do that. And I will caveat that olaparib is actually already FDA approved for women who have early stage BRCA mutated breast cancer. And so this study is, not too divergent from that train of thought. Olaparib already has an approval in women with breast cancer, and we are trying to do the same thing for men with prostate cancer. So with regards to the eligibility, it's for patients who have intermediate or unfavorable intermediate risk disease or high risk disease defined by a Gleason score that's 7 or higher, a PSA greater than 20, or evidence of disease that may be outside the prostate on MRI. For patients who have intraductal carcinoma, all of those patients will be eligible independent of what their PSA, Gleason score, or T-score is. With regards to the genomic alterations that are permissible, this study is enrolling patients with both hereditary germline alterations, meaning mutations they were born with, or mutations that they're not necessarily born with, but they're just in their tumor cells. And so the eligible mutations are BRCA1/2, PALB2, ATM, CHEK2, CDK12, the RAD51 family genes, and we won't go through all of those, but there's a listing of about 4 genes, BARD1, FANK-A, and BRIP1. And really it's for those individuals who are candidates for surgical resection. Patients can enroll if they've got pelvic lymph nodes, as long as the pelvic lymph nodes are less than 2 centimeters in size, and they need to be a good performance status and ability to kind of tolerate 6 months worth of therapy. And I've sort of already given you the sites that have the study open. Of course, I am always available to answer questions about this study. And it's enrolling through the Hoosier Cancer Research Network, which is a wonderful research organization that helps conduct clinical trials.
Absolutely. Thank you. And is there anything else new and exciting? Because this has been really helpful overall, but for early stage prostate cancer treatment, is there anything else that you would like to share with attendees? Dr. McKay, I'll start with you, and then Dr. Hafron.
Sure. I think just across oncology in general, there's been a lot of enthusiasm around neoadjuvant strategies. And I think we've come a long way from where we were a decade ago or 20 years ago, when some of the first neoadjuvant studies were conducted. So I think this is technically not yet the standard of care in prostate cancer, though many studies are being done looking at trying to see if this will become a new standard of care in the future. There's large phase 3 trials that are currently ongoing, some that have completed accrual and some that are going to begin accrual, testing various neoadjuvant strategies, and not just PARP inhibitors, but with hormonal agents as well. And so, the concept for neoadjuvant therapy is that you give a treatment before a surgical resection when the tumor is still intact. It shrinks down the tumor. It may make the surgery easier. And then actually, when you take out the tumor, when you cut everything out after you've given somebody treatment, you can actually look at the tumor underneath the microscope and have an assessment of like, well, what happened with the treatment? Did it die down? Is there any cells remaining? Or maybe there's a very little amount of cancer cells remaining. And certainly in breast cancer, the pathologic response has actually been very, very informative to inform prognosis after somebody's received neoadjuvant therapy. And there's lots of biomarkers, I think, stepping away from the neoadjuvant discussion a little bit, there's lots of biomarkers that I think are just revolutionizing this space. Some, to name a few, are Decipher, which is an RNA-based molecular test, Artera AI, which is a path test that takes your biopsy or radical prostatectomy specimen and looks at, kind of puts it into their AI algorithm to generate a risk score that's associated with how aggressive the tumor looks like under the microscope. And there's other really novel tests that are being done to ask the question around who needs treatment intensification, who needs more, and also to ask the question of who needs less. So not everybody needs the kitchen sink, and there's many patients that have prostate cancer that don't necessarily need all of that. And then, of course, the precision medicine advances. How can we better personalize our therapy based off of the genomics of that individual person or that individual tumor, I think is going to be critically important for the future, with the integration of AI to help accelerate our ability to be able to do that.
Thank you, Dr. McKay. Dr. Hafron, anything to add?
Yeah, I mean, just like Raina, showed all these exciting trials. We just completed a trial that was some of the most exciting technology I've seen. It was called the Vapor 2 trial, and it's based on focal water vapor technology. So instead of doing radical surgery or radical radiation and treating the whole gland in a patient that has prostate cancer, can we localize the treatment or apply focal therapy just to the tumor itself within the prostate? And that's what this focal water vapor technology did. It's pretty awesome technology, and it's designed to treat cancer with thermal energy stored in sterile water vapor. The ablation system delivers this targeted and precise application of thermal energy using a simple transurethral or through the penis procedure. The awesomeness of this technology is that we use the MRI images and surgical navigation to place this needle directly into the tumor so that we are assured that we are just treating the cancer and not treating the rest of the prostate. Once we place the needle into the tumor, using the system, we are able to basically deliver steam. And the nice thing about steam, what we noticed in the trial, is that steam kind of just surrounds the tumor. It doesn't travel to other parts of the tumor. It's different than other heat-based energies because you don't get a lot of collateral damage. So I think the trial's accrued. We're waiting for the results, but it looks very promising in the patients that we treated, and potentially can offer patients an alternative therapy to radical surgery or even to radiation, where we apply focal or localized water vapor to treat the tumor itself.
Wow, thank you very much. And Dr. Hafman, I'm going to stay with you because we're going to turn our attention to treatment for advanced stage prostate cancer. I understand that you're running a new clinical trial at your institution, and it's looking at a new type of PARP inhibitor and if it's relevant for people with advanced hereditary prostate cancer. Can you please share more?
Yeah, the EvoPAR Prostate 01, is a phase 3 double-blind, placebo-controlled 2-cohort study that's looking at a new PARP saruparib in combination with new hormonal agents in patients with metastatic castration-sensitive prostate cancer, or MCSPC. And what's cool about this trial is that we're looking at in patients with and without mutations. Saruparib is a first-in-class. It's a new PARP inhibitor, and it's a very highly selective PARP inhibitor. And preclinical trials, phase 1 and phase 2 data, shows it has increased potency and improved physiochemical properties versus the PARP inhibitors that we've used in the past. The safety and efficacy of saruparib plus new hormonal agents for the treatment of MCSPC and MCRPC prostate cancer are being assessed and have already been assessed in phase 1, phase 2 studies. And the initial data is very exciting because we found that it can be safely combined with enzalutamide, abiraterone, or darolutamide. And there were low rates of hematologic and GI or gastrointestinal toxicities, as well as low rates of dose reductions or discontinuations. So bottom line here, saruparib can be safely combined. Saruparib appears to be a better PARP than has been previously published. But now in this trial, we want to evaluate in over 1,200 patients whether this leads to improvement in outcomes. So half the trial is looking at patients with mutations, plus or minus saruparib and an ARPI. The other half of the trial is looking at patients with mutations and whether saruparib plus or minus an ARPI improves, or ARPI plus or minus saruparib improves outcome. So very exciting trial, very large scale multinational trial that will have a significant impact in our management of patients in the MCSPC space.
And we do have that QR code. Again, these slides will be shared, but if you want to take a quick pick, you can. Otherwise, we're going to move forward. Dr. Hafron had mentioned these terms, but Dr. McKay, can you explain the difference between these two that we see on the screen, castration-sensitive prostate cancer and castration-resistant prostate cancer?
Yeah, absolutely. So castration-sensitive prostate cancer is a term that's used to define a cancer that's responding to testosterone suppression. So the backbone of treatment for patients who have prostate cancer, when they generally need systemic therapy to treat their disease, whether localized, recurrent, or metastatic, is something called hormonal therapy. The hormonal therapy is kind of a misnomer because it's kind of anti-hormonal therapy because we're taking away somebody's testosterone and dropping it down to very low levels. So castration-sensitive disease is cancer that, when you do that, responds. The PSA goes down, the tumors stabilize on the scans, or they shrink on the scans. Castration-resistant disease is a term that's used to denote cancers that, despite having a very low testosterone and being in an environment where the testosterone is very low, the cancer continues to grow. And in that context, there are different treatments that are utilized. It could be PARP inhibitors, it could be radiopharmaceuticals, it could be chemotherapy. There's certain immunotherapies that could be indicated. So it just denotes a more resistant state of the disease.
And with that in mind, can you share what else is new or exciting for treating advanced prostate cancer?
Yeah, I started to chat a little bit about that. So for advanced disease, I think some of the up and coming treatments are radioligand treatments. So these are treatments where there's a certain target that's on the cell surface, whether it be PSMA, which is prostate-specific membrane antigen, or some other target that's on the cell surface. And then there's a linker that links to some sort of, what I like to call it as a payload, some sort of, a toxic thing that's going to get delivered to the cell. And that toxic thing can be a little bit of radiation, like in radioligand therapy. So there's a new targeted radiation therapy called, the trade name for it is Pluvicto, that's FDA approved for patients. But there are other drugs that are being developed, with different energy sources. They could be an alpha particle, it could be a beta particle. There's a different kind of energy source, and they could target a different protein. So I talked about PSMA, but they could target STEAP or KLK2. Take that same concept of a target, linker, payload that's going to be toxic to the tumor. And now, instead of putting a radiation particle as your payload that's going to kill the cell, you could actually put a little chemotherapy there. So now, instead of giving chemotherapy that just goes everywhere, there's antibody drug conjugates that basically deliver chemotherapy directly to the cancer cells. Some of the terms that you may have seen around these drugs are smart bombs, because they are very targeted treatments that deliver chemotherapy directly to the cancer cell. Then, of course, there's precision medicine strategies. So these are strategies where we're trying to understand the molecular makeup of that unique individual's tumor and target treatment based off of that. There's actually a clinical trial that's open through the cooperative groups, through the NCI. Across the US, many sites have this trial open. It's called the PREDICT study, and it actually takes an individual's DNA and RNA. We get the data back and basically strategizes which treatment they should get based off of their genetic makeup of the disease. And so there's a chemotherapy arm, there's a targeted therapy arm, there's a standard of care arm, and it's all based off of the patient's underlying genomics. And the last item to highlight are bispecific antibodies. And They're a little bit different than the concept of a, target linker protein, but they're similar in that they're targeting a protein on the cell surface, but now they're linking to the immune system. So instead of linking to a chemo or a radiation particle, they're antibodies that link to your T cells to basically say, how do I get the immune system in the same space as where the tumor is? Because in some contexts, your immune system is your greatest, army against the cancer. So how can you bring the immune system close to where the tumor is and let the immune system do its thing? So I'm super excited about many of these items and these precision medicine strategies and newer forms of drugs that are being tested in prostate cancer.
Absolutely. And Dr. Hafren, what about you? What do you find particularly exciting for advanced treatment?
Yeah, just as Raina highlighted, there's so many great studies being done, so many great concepts and novel mechanisms of action to treat it. One that I find very interesting, we've been very excited about, is the SYNC-T Legion 100. And this is a clinical trial studying SYNC-T SV102, which is an investigational immunotherapy for MCRPC. And the cool thing about this trial is that we combine cryoablation, which is freezing a portion of the tumor, whether it's in the prostate or the lymph node or any soft tissue. And then once we freeze that area, we infuse this like antibody cocktail right into the area that we froze. And this combination of using freezing or cryotherapy, releasing these antigens, is we create a systemic personalized immune response. So that this personalized immune response to the tumor will lead to systemic responses. So even if we're treating the prostate, we potentially, trials being done now, could treat lymph nodes, metastatic disease elsewhere throughout the body. Just in the early stages of this, right now we're evaluating the safety, a little bit of the efficacy in SV102 or SYNC-T in these patients with MCRPC. Hopefully, next time we present, I'll have more data to share.
Absolutely. One to watch for sure. Thank you, Dr. Hafren. And before we close out this section, I'm just going to point out two trials that are being shared on Force's webpage. The QR codes are here for you. But again, any studies mentioned during this presentation, as well as here on the slide, are available in the resource guide in the resource tab on your console. But we're going to move forward because we have some closing thoughts we want to get from our experts, because this has been an informative, incredible panel. And I know you all want to go to the breakout room. So just one last question. And Angie, I'm going to start with you. How do we get more men to have genetic testing?
So I think one of the reasons why men might not have genetic testing is they might not be thinking or asking about family history. And sometimes it's sort of, maybe sometimes it's the women in the family who are having those conversations. So if you're interested in genetic counseling or testing, but you're afraid you don't have family history, try to figure out who it is in your family that collects that information and ask them to share it with you so that you can see if there's risk factors that might mean you're at risk or that your cancer is an inherited cancer. And also think about the possibility that you might think, well, I have prostate cancer, but I don't have any sons or I don't have any male relatives. Remember, a lot of those genes I mentioned are associated with other cancers that can affect both men or just women. And so think about that too when you're thinking about who might benefit from genetic testing besides me. It could be some of your female relatives, not just male relatives. And then talk to your primary care physician, talk to your oncologist, tell them that you're interested in seeing about genetic counseling and testing. And if you aren't sure, if you at least have genetic counseling, you can get information from a physician or a genetic counselor about what testing would entail and the benefits and risks, so you can make a truly informed decision. And the main goal of genetic counseling and testing is that we hope that by identifying families at risk, they can avail themselves of early screening so that we can either prevent cancer by taking measures to prevent the chance of cancer developing, or we can identify cancer at an earlier, more treatable stage so that if there's been a family where many people have died from cancer, we can change that course. And there are different times when genetic testing might be difficult. Sometimes when somebody's going through a diagnosis, they have so many things going on, that's not the right time. Lean into your family. If you want that information, if you want somebody to help you collect the family history information so that you can proceed without doing all that other work, or if you want to wait until you're past, maybe a certain part of your treatment, then that's okay too. But just talk about it. And like I said, it could be valuable, not just for you. You've heard about how your genetic makeup can actually affect what kind of trials you might be eligible for, what kind of treatments, but other family members as well. And don't be afraid to ask questions. And if you get a no, or I don't know how to refer for genetic counseling, Force has amazing resources that can help you have those conversations with your healthcare providers.
Very helpful. Thank you, Angie. Dr. McKay, same question.
I think for me, it's education. Many men don't know that genetic testing exists or its benefits. And I think, the family focus, like emphasizing that, when patients ask me, why should I get tested? Quite honestly, it's 4 reasons. It's prognostic, because it can help inform your prognosis. It could be predictive. If you have a cancer, it could potentially help guide therapy for you. And the 2 additional reasons to do germline testing is 1, cascade testing for family members. So it can help inform first-degree relatives what to do, sons, daughters, grandchildren. And the last one is actually screening for other malignancies should somebody be found to be positive. Like if you're found to have a mutation that also connects you to colon cancer, for example, well, it's early colon screening. So those 4 reasons are my key around why. But I think the barriers are education, focusing on the family, accessibility, reducing the barriers from an insurance standpoint, coverage standpoint. I think a lot of times people have questions about, is the test covered? What's going to happen with life insurance? And then also educating the doctor, because if it's something that's never offered to a patient, then that is another barrier. So.
All great points. And Dr. Heffron, round us out. What is a way to get men to get genetic testing?
I think there's a huge gap in provider education. What we focus on, particularly in urology, is educating the urologists the value of genetic testing. And I think it's important as a patient to be a good patient or a good consumer, and sometimes advocate for yourself, and don't assume that your provider, your urologist, is well informed. This space is moving very quickly. But education like these types of webinars, education through the Force website, use that as ammunition or foundational work support, so that when you go see your provider, that you can advocate for yourself or your family members.
All very helpful points. Thank you so much. And on behalf of Force, I want to thank our incredible panelists. They're not going anywhere, and neither should you, but I do have a few points very quickly before we move to the breakouts. Please take a moment to scan this QR code to take our feedback survey. We will do some outreach, but just wanted to give you an opportunity to do that now over on your phone or mobile device. And your feedback helps us to make sure that we're meeting your needs for our programming. And hereditary cancer updates. You may have gone to the one in May. This event occurs every other month. So you want to make sure you have July 22nd at 2 p.m. Eastern time on your calendar. That is when the next hereditary cancer update will occur. You can register through this QR code. You will receive communication regarding it, and these slides will be made available, but we wanted to give people an opportunity. And lastly, just making sure that you connect with Force. If this is your first time interacting with us, or there are members of your family or community that should be connected to Force, here's how you can do so.